Dr. Dushantha Madagedara, consultant respiratory physician. Welcome all of you to webinar on pleural diseases organized by the Pleural Disease Assembly of Sri Lanka College of Pulmonologists. It is my great pleasure and privilege to chair this session as a chair of the assembly with my co-chair, Dr. Damit Nandadeva, secretary of the assembly. And I warmly welcome all our speakers, resource persons from overseas as well as local, and all the participants for this very important webinar on pleural diseases. Now, as you all know, as a clinicians, it is immaterial whether it is in the pulmonology, that means respiratory units, or medical, or pediatric, or surgical unit. The pleural diseases are one of the common clinical problem we will encounter day-to-day practice. It is utmost our privilege to enlighten and educate and update all medical fraternity of the country as well as our region about the pleural diseases and the current knowledge on the different type of pleural diseases. We organize this webinar to update you on the different aspects from the basics to the chronic problem of a pleural diseases, where we are expecting to update our medical officers, postgraduate trainees, clinicians, and senior registrars and pulmonologists about the current knowledge of different type of respiratory pleural disorders. And these 4 lectures, we are focusing on the different aspects of a pleural diseases. And we will going to have a question and answer session at the end of the webinar, and you can post your questions on chat box, and we will be directed to the respected speaker at the end. And hope this webinar will be definitely improve your knowledge on the current knowledge and update the current status of management of different pleural diseases, from investigation to the chronic refractory pleural effusion of a malignant pleural effusion. It is my privilege as a chair of the Assembly of Sri Lanka College of Pulmonologists to introduce our first speaker, the practical talk on a practical approach to diagnosis of pleural effusion, Professor Y.C. Gary Lee, friend of us, and is known to all of us for his and he was the oration of pleural diseases, and he's a physician and the director of pleural services, Sir Charles Gardner Hospital, Perth, Australia. And once again, thanks on behalf of the college to accepting my invitation to be with us today. And also, he's helping our trainees for their postgraduate training in overseas. Gary, thank you very much for being with us. And I'm inviting Professor Gary to talk on the practical approach to diagnosis of pleural effusion. Yes, Gary, to you. Thank you very much.
Good afternoon, and thank you for the opportunity to come and speak to you again in Sri Lanka. Today, my job is to talk about the diagnostics of pleural effusions. Pleural effusion affects 3,000 people per million population a year, and at the last count, there are more than 60 different causes of pleural effusions. It can affect male and female, old or young, rich or poor, black or white. In the British Thoracic Society Pleural Diseases Guideline, once you identify the pleural effusion, you need to aspirate the fluid. If that biochemical analysis did not show any answer, then you might need advanced imaging such as CT scan and maybe additional tests as it's appropriate for the patient's conditions. Pleural tissue biopsy might be necessary, be it imaging guided or thoracoscopic. The first step towards pleural fluid analysis is to look and smell. If the fluid is pus or blood, then you already get the answer of empyema or hemothorax. If the fluid is turbid, It may be empyema or it might be a chylous effusion. If it is an empyema, it is neutrophilic. If it is chylous effusion, it is lymphocytic. Another way to find out is to centrifuge the fluid. If it remains turbid, then it is a chylous effusion. If after centrifuging, then the supernatant becomes clear, then it is an empyema. So if it is a chylous effusion, you then need to separate whether it is a chylothorax or pseudochylothorax. Both of them will look creamy, but the chylothorax is characterized by the presence of chylomicrons and high triglyceride level, whereas the pseudochylothorax is made up of high cholesterol levels and often the presence of cholesterol crystals. You also need to smell the fluid. Urinothorax is usually best diagnosed by smelling the fluid, such as in this case of a 60-year-old female who has got metastatic cancer and bilateral hydronephrosis, and she has bilateral renal tract obstruction, and the fluid is transudative and has very high fluid creatinine. But if you can smell urine in the fluid, then that is the best test for urinothorax. Most of the time you need to do biochemical analysis. In the BTS guideline, in a patient presenting with an undiagnosed pleural effusion, it is recommended that 60 ml of a diagnostic fluorescentesis is adequate. Large volume drainage up to 1.5 liters may be needed if the patient is very breathless. Complete evacuation with a chest tube is only required if you clinically suspecting a pleural bleed or an infection, so blood or pus. This is what we usually do with the 60 ml of fluid that we aspirate for diagnostic fluorescentesis. We use 5 to 10 ml for testing for protein, LDH, glucose, and other biochemical tests, bacterial plus or minus TB culture. We'll put about 1 ml into a blood gas syringe, and we'll put 2 ml of fluid into each of the blood culture bottles, and the remaining 50 ml or so of fluid we send for cytology. So the question is, why don't we drain it all? Well, if the initial tap is non-diagnostic, you need to do next step investigations, and that often involve imaging guided biopsy or medical thoracoscopy. Having fluid present provides a cushion against the lung and is technically safer and easier for subsequent invasive procedures. Also, if the patients turn out to have a malignant effusion, you can perform a definitive procedure for long-term fluid control, such as pleurodesis or indwelling pleural catheter placement at the same setting. Otherwise, you need to wait for the fluid to reaccumulate, readmit the patient for treatment. So why 60 ml? That is because most hospitals, the largest syringe is 60 ml, and it is then attached to a 21 or 22 gauge needle if you just need to have a diagnostic fluorescentesis. However, if you need to drain 1.2 liters, at the very least, you need to put in a IV line such as an angiocath. And if you need to drain the patients completely, you often would need a chest tube. Clearly, the larger the needle you're going to stick in, the more pain it involves and the higher is the risk, and you might require hospital admission if you want to proceed with tube drainage. You might ask, is 60 ml enough for cytology? Well, to date, all published studies shows that no significant increase in sensitivity exists for cytology, even if you send more than 50 ml of fluid. You're all familiar with Light's criteria and the separation of fluid into transudate and exudate, but moving forward, what we really need are disease-specific markers in the pleural fluid that can tell us the exact diagnosis. So in this talk, I'm going to talk about the common pleural fluid diagnostic markers are used routinely and some new molecular diagnostic tools. So tests I routinely request: protein, LDH, differential cell count, pH, and glucose. Culture for infection and cytology for malignancy. The tests that I only request if clinically indicated: N-terminal proBNP for heart failure, adenosine deaminase for TB, mesothelin for mesothelioma, flow cytometry for lymphoma, chylomicron and triglyceride for chylous effusions, amylase if I'm suspecting pancreatic disease or esophageal rupture, and beta-2 transferrin if I suspect a CSF leak. N-terminal proBNP. Separating transudate and exudates using Light's criteria has some shortcomings. It misidentified transudate as exudate in 20 to 40% of patients on diuretics, presumably because the diuretics drives the fluid out of the pleural cavity faster than it drives the protein out. Also, Light's criteria do not establish the cause of the transudate, whether it is cardiac, hepatic, or renal in origin. An N-terminal proBNP of greater than 1,500 picogram per ml in the pleural fluid strongly suggests a heart failure pleural effusion. So in my practice, if it is a transudative effusion and it has a high N-terminal proBNP, it helps me to determine that it is of cardiac origin versus other transudative causes. Even in exudative effusions, if you measure the N-terminal proBNP, you might often find that it is raised because a concurrent cardiac failure component hidden in an exudative biochemistry is quite common. There are a lot of recent data showing that cardiac component is common in malignant pleural effusion and parapneumonic effusions, especially in the elderly. And there's a lot of papers showing that both pleural fluid and blood N-terminal proBNP are both very useful, with the pleural fluid N-terminal proBNP may be slightly better than the blood. N-terminal proBNP can also correct almost 100% of those samples who are misclassified as exudate by Light's criteria. This is an example. An 88-year-old man with significant cardiac and vascular disease presented with a left effusion and a significant level of breathlessness. The attending team tapped the fluid and determined that it was an exudate, but we decided that this is a classical clinical diagnosis of a false exudate because the patient has a strong clinical suspicion of left heart failure. He's on diuretics. The protein is borderline in the exudate range, and the LDH and glucose, etc., are unremarkable. So we measured the N-terminal proBNP and find that it was greater than 7,000, with the usual cutoff for heart failure being 1,500. So we diuresed the patient without performing any further invasive procedures. Adenosine deamylase, I'm sure you're very familiar with it in Sri Lanka as a workup for TB. So ADA in pleural fluid is elevated in most or all of TB pleural effusions. But you should also remember that it can be elevated in other infections and occasionally with certain cancers and connective tissue diseases, especially rheumatoid. A high ADA level suggests TB or some other significant pathologies, as I just mentioned. So in any case, the patient needs further investigations. In a place like Australia, where TB effusion is quite uncommon, I most often use ADA as a rule-out test, so that a negative ADA essentially excludes TB pruritus. Soluble mesothelin-related protein, otherwise just called mesothelin, is the first FDA-approved biomarker for mesothelioma and is raised in the pleural fluid and serum of patients with mesothelioma. However, a negative value does not exclude mesothelioma because about 50% of the patients presented with a normal mesothelin level at the time of presentation. Those who have renal impairment may have an artificially raised mesothelin because mesothelin is renally excreted. The pleural fluid mesothelin level is perhaps a little bit more sensitive and useful than the blood mesothelin level if the pleural fluid analysis is available. A raised mesothelin level in the absence of renal impairment is strongly indicative of pleural malignancies. Most likely is due to mesothelioma, but you must remember occasionally it can be caused by other metastatic cancers. For example, this 74-year-old man who has a left pleural effusion and a significant asbestos exposure history underwent surgical pleural biopsies only to find that they were all non-specific pruritus. So he was referred to me to decide whether he's got benign asbestos pleural effusion or do we need to still exclude mesothelioma? We performed a mesothelin level in the blood, and it was sky high at 7 micromolar. And the cutoff for mesothelin in the blood is usually 2 or 2.5. So this is very likely to be a case of mesothelioma. We perform a PET scan and ordered a CT-guided biopsy at the AVID areas to confirm that it was mesothelioma. Beta-2 transferrin is a protein that is only found in CSF. So when it's present in the pleural fluid, it usually means that there's a dural pleural fistula, or if the patient has a ventricular pleural shunt. We now look at the investigation for pleural infections. As you know, pleural fluid pH measurement is quite important in determining whether the patient has a simple or a complicated parapneumonic effusion. And the low pH predicts the need of pleural fluid drainage. And we have shown that pleural fluid pH accuracy is critically depending on the way you collected the sample. The accuracy is affected by many factors. It must be measured using blood gas machine, not pH paper or pH machine. You have to squeeze out the air in the transport syringe because the presence of air raises the pleural fluid pH. You need to avoid having lignocaine carried over into the fluid because the commercially available lignocaine has a pH of 5 or 6 and it will significantly reduces the pleural fluid pH. There's no need to transport the fluid on ice, but you have to measure the pH within about 3 or 4 hours, otherwise it will not be reliable. Alternatively, you can use pleural fluid glucose, and the low glucose less than 3.3 millimolar per liter is similar to a low pH of less than 7.2. But you need to make sure that the patient is not having hyperglycemia or uncontrolled diabetes, which will affect the results. The microbiological yield from culture of the pleural fluid has always been poor, but we know that this can be improved using blood culture bottles to transport the fluid. Several papers have shown that if you put the pleural fluid into blood culture bottles, it can increase the yield by about 50% from sending the fluid in sterile container only. This is because of increased capture of the bacteria in the anaerobic vial. And we have also shown that if you inject 2 ml, 5 ml, or 10 ml of the pleural fluid into the culture bottles, the yield does not increase. So 2 ml is enough. So how else can we improve the yield of the bacterial culture? Well, if you ask yourself, if you had the bacteria, where in the pleural fluid would you like to live? Would you like to live on dry land, on the pleural tissue, or in the pleural fluid? Well, the Oxford team published this very useful pilot study using ultrasound-guided pleural biopsy in patients with suspected pleural infection, and shows that the blood culture only have about a 10% sensitivity of capturing a microorganism. The pleural fluid may be just over 20%, but if you do a pleural biopsy, it has almost a 50% chance of capturing an infective organism. And 3/4 of these patients with a positive pleural biopsies were already on antibiotics, which means that the biopsy is still worthwhile if the patient has been started on antibiotics, and also the antibiotics we are using for pleural infection is not that effective. What about investigations of malignant pleural effusions? Ultrasound that we often do now can aid the diagnosis of pleural malignancies. The presence of pleural thickening, diaphragmatic thickening, and nodularity on ultrasound is as good in sensitivity in picking up pleural malignancy as it is on CT scan. The CT features of pleural malignancies include circumferential thickening more than 1 centimeter, pleural nodularity, and mediastinal pleural involvement. The more of these 4 that are present, the more likely that the patient has pleural malignancy. Also, contraction of hemithorax and fissural nodularity can be common. For echoscopy, whether it is medical or surgical, are indicated if there are no other less invasive means to obtain pleural tissues from the targeted sites. Thoracoscopy allows the biopsies under direct visual guidance. This is a patient with mesothelioma and a trapped lung. There are nodules on the diaphragmatic pleura, parietal pleura, and visceral pleura. And sometimes these lesions can be quite tough if you're using flexi-rigid pleuroscopes. And so we were one of the first groups to start using cryobiopsies to take bigger samples using a cryoprobe. This is one example. But we have published, and so is other groups had, that pleuroscopy is not a gold standard and false negatives do occur. The most common situations where false negative occurs in all these series are mesothelioma. The negative predictive value is around 90%, but if you are in endemic areas with a high incidence of mesothelioma, you need to be careful. So why is pleuroscopy not always useful, and why can it fail? If you look at this case, then you can see the parietal pleura, visceral pleura, and the diaphragmatic pleura are all diffusely thickened. So direct visual guidance does not really help, because direct vision is not as good as molecular vision. We don't really know where the cancer is hiding underneath this pleural thickening. So percutaneous biopsy guided by PET scan is an evolving option. In selected patients like this one, where you can see he's got diffuse pleural thickening, but clearly it is a lot more avid in the anterior parietal pleura. So we ask for a CT scan and a CT guided pleural biopsy targeting that particular area that is most avid on the PET scan. I want to briefly mention two new molecular diagnostic tools. One is cell-free DNA, or so-called liquid biopsy. Cell-free DNA comes from DNA fragment that get shattered off from necrotic tumor cells into the plasma or body fluid like the pleural effusion. And it allows detection of tumor genetic mutations, such as EGFR mutations, using next-generation sequencing. And it has a high sensitivity and specificity. So in patients with non-small cell lung cancer with malignant pleural effusion and suspected driver mutations, then you can send the blood or pleural fluid, including the cell block, for the DNA testing, and you will have a 90% chance of capturing those mutations and negate the need for tissue biopsies. But a word of warning, beware that the sensitivity of the test is very much dependent on the laboratory technology you have available at your center. In this patient, for example, he has got metastatic lung adenocarcinoma, EGFR mutation, but started to relapse despite TKI, and you suspect resistant mutations. So instead of doing a biopsy, we retapped the pleural effusion and was able to detect the T790M mutation in the pleural fluid without having to do a biopsy. There are two new markers that has transformed the diagnosis for mesothelioma. One is the BAP1 gene and one is the CDKN2A fluorescent in situ hybridization, otherwise called FISH. The loss of BAP1 nuclear staining in mesothelial cells will confirm the diagnosis of mesothelioma, and the fluorescent in situ hybridization showing a homozygous deletion of the CDKN2A gene on chromosome P16 will also confirm malignancy, especially useful in sarcomatoid mesothelioma. So we now experience the presence of these two tests has significantly made diagnosis of mesothelioma much easier. Don't forget that pleural effusion is not just heart failure, infection, or cancer. Pulmonary emboli, for example, often causes pleural effusion. In patients with pulmonary emboli proven on CTPA, almost half of them will have a pleural effusion. They are usually very small, and if they are large, you need to consider alternative causes. Drug-related pleural effusions are common. They're often eosinophilic. Very often these days they are due to clozapines. Biopsy is usually not very rewarding. They would usually only show non-specific inflammation. Diagnosis is by exclusion, and very seldom do we re-challenge the patient with the same drug. Last but not the least, there are at least 60 different causes of pleural effusions, and most effusions at the moment are given one diagnosis and assumed to arise from one single etiology. We believe that this is way too simplistic, but the future relies on disease-specific markers to help us decode coexisting diseases and contributing etiologies. Last but not the least, I'd like to thank my hardworking clinical and laboratory group that has contributed to a lot of the data that I've shown you today. If you're interested in Pleural research, come and talk to us, and do follow us on Twitter. Thank you very much for your attention.
Thank you very much, Professor Lee, for that very illustrative lecture. We'll focus on questions at the end of the session in the interest of time. Let me introduce our next speaker. It's Dr. Rakesh K. Panchal. He will be speaking on thoracic ultrasound and ultrasound-guided interventions, what's new. Dr. Panchal is also a friend of the Sri Lanka College of Pulmonologists. In fact, we've worked with him previously. He's been on site in Sri Lanka for a pleural and ultrasound workshop a couple of years ago. Dr. Panchal is a consultant respiratory physician and lead clinician for pleural disease and interventional pulmonology at the University Hospitals of Leicester NHS Trust in the UK. And his main interests are pleural disease and interventional pulmonology. Without further ado, over to you, Dr. Panchal.
Hello, everybody. My name is Rakesh Panchal. I'm a respiratory physician at Glenfield Hospital in Leicester. I'd like to thank Dr. Madagadera and Dr. Damit for inviting me to this Pleural Disease Assembly webinar to talk about thoracic ultrasound and guided procedures. It's always a pleasure to work with the Sri Lanka College of Pulmonologists, and we've worked together on workshops and the RESPI meetings in the past. So in the next half an hour, I'm going to talk to you a little bit about the utility of thoracic ultrasound with regards to a number of different pleural disease areas as listed on this slide. The purpose of this talk is not to teach you thoracic ultrasound, but to teach you more about how thoracic ultrasound helps in all these different aspects of pleural diseases that you will encounter. So pleural ultrasound complements your stethoscope, and I think it's almost the new stethoscope now. Stethoscopes have altered and developed and changed from René Laennec's period in the 18th century. And similarly, ultrasound machines have also evolved from large machines you'll see in radiology to handheld machines which can be used at the bedside. There's been an upsurge in thoracic ultrasound over the last 10, 15 years. It's been around for a lot longer than that, but a lot more interest and widespread use of it, particularly in the last decade. In the UK particularly, this came about from the rapid response from the National Patient Safety Agency, which said that there was adverse harm from pleural procedures and chest drain insertion in the absence of use of ultrasound. And in turn, it led to the British Thoracic Society guidelines in 2010, which recommended all pleural procedures for effusion should be done under ultrasound guidance. The BTS pleural guidelines are now over 12 years old and are due to be renewed this year. Most people who trained in thoracic ultrasound in the UK followed the Royal College of Radiology recommendations for medical specialties on what was known as the Level 1 RCR curriculum. And this has now been superseded by the BTS thoracic ultrasound training recommendations, which were published in 2020. And I'd strongly encourage those of you who are interested in this to read these documents, which are freely available. Similarly, there are a number of excellent articles now available on the utility of ultrasound and the use of ultrasound in different procedures. And I've given you some references here, which are freely downloadable for those of you who are interested. So in my own practice, ultrasound has certainly changed. So we had this Philips machine when I first started. I think there's an older one than that, but we've still got this available now. But now we have this Sonocyte machine here on the right. And we also have this Clarius machine, which is wireless and can be used on a tablet, and also this Butterfly machine. So you can perform ultrasound right at the bedside of the patient. And I routinely take these devices around on ward rounds when assessing patients and in clinic. There are an array of ultrasound probes available. However, with regards to thoracic ultrasound, you'll be pleased to hear that only two are useful: a curvilinear probe here on the left and a linear ultrasound probe. You don't need any of the others. So on the left here, you can see the linear ultrasound probe. This gives you high resolution of superficial structures, but not much depth. And a lot of you will be accustomed to using this for vascular access. The curvilinear probe gives you a wider array and much more superficial, it gives you superficial detail, but also a lot more depth, and is what we routinely tend to use when we talk about thoracic ultrasound. So when performing thoracic ultrasound, it's important to understand one's limitations. On a day-to-day basis, you'll use it largely for fusions. But if there's any complex ultrasounds you come across and you're not quite sure of what you're seeing, it's always important that you have access to experienced colleagues, and usually radiology will be our first port of call. When performing ultrasound, there are three real modes. There's the brightness or B mode, which is the conventional mode. There's motion or M mode, and obviously we have color Doppler. As I said, linear and curvilinear are the main probes. So a curvilinear probe has a low frequency of 2 to 5 megahertz and is useful for the depth and evaluation of deep and superficial structures, whereas the linear probe is a high frequency structure, usually useful for evaluating the chest wall and the parietal pleura. In normal thoracic ultrasound, as you'll see on this image on the right, you'll see this sort of image. The lung is a poor transmitter of ultrasound waves. So you'll see the subcutaneous tissues, the intercostal muscle and the fascia, and then you'll see this sort of the lung beneath it with this echo bright line in the middle. This echogenic line, known as the pleural stripe, is where the viscera and parietal pleura come together. And you'll normally see in B mode ultrasound using a curvilinear probe that this line will be sliding, what's known as a normal lung sliding sign. Okay. Sometimes if you're seeing the lung on top of the diaphragm, you may see a curtain coming in, because again, the lung is a poor transmitter of ultrasound waves. So you see this curtain coming over the diaphragm and moving out with respiration. You may also see comet tails or B lines. These are vertical bands, which are known as reverberation artifacts, and they normally imply foci of calcification or discrete air collections and are of not real concern. So let's look at a typical ultrasound image. So this is, you can see a curvilinear probe because you see this convex shape and you see this large array giving you a lot of depth. So you can see here there's a curvilinear probe. You can see an anechoic effusion here in black. You will see these blue arrows demonstrate where the parietal pleura and the subcutaneous structures can be seen. And the purple arrows indicate where the diaphragm is. And beneath the diaphragm, depending on if you're on the left, you'll see the spleen, and on the right, you'll see the liver. You'll see the costophrenic angle here, and you can see this atelectatic or collapsed lung in the middle. Similarly, here you can see a very horizontal line. So this is linear, a linear probe you're using for your thoracic ultrasound. At depth, you can see that there's a large anechoic effusion. We know it's a linear probe. And then you can see the superficial structures in much more detail and higher resolution. So you've got the dermis, the subcutaneous fat, the intercostal muscle and fascia, and then the rib. And then around the blue arrows will show you where the parietal pleura lies. And the purple arrows show the diaphragm at depth. But as you can see, you don't get much depth, so the diaphragm is not clearly seen with the linear ultrasound. It's much better for superficial structures. So when majority of you will be performing ultrasound for effusions, and when we see effusions, we describe effusions in four, or put them into 4 categories. In yellow here, the yellow box, you can see this is an anechoic effusion. So this is an effusion which appears very dark black. Sometimes this may be a transudate. A complex non-septated effusion. So this, again, there'll be no septa seen, but the effusion will not be anechoic, but maybe a little bit more, has more debris in it or more proteinaceous material in it, and that may indicate an exudate. You could get up to a malignant effusion or a parapneumonic effusion. You will then get septations being formed. So you can see this is a septated collection. So septa imply fibrinous structures developing, and this is going to most likely be an exudative effusion. It could happen in infection or malignancy. And then you may see a very echogenic collection. So this is where it's lots of proteinaceous material and debris in it. And sometimes it can have a very similar consistency to the liver. And if it's very echogenic, it may be blood or it could be an empyema. So when we're performing ultrasounds for effusions, a lot of people always ask, well, how much fluid is in the chest? And there are a number of different algorithms available. And you can use your ultrasound probe in 3 different planes to measure depth of the effusion, to estimate the volume of fluid. And there are a number of different equations. There's this nice paper by Magid Hassan in the Journal of Ultrasound, which looked at a number of different equations and found that when you're doing a image, which in where you've got the collapsed lung, you've got the diaphragm being visible, and then you measure the height of the effusion, so per rib space. So you take your ultrasound probe to the highest point on the chest where you can see the effusion developing, and then you count down rib spaces until you see the diaphragm. You then measure in centimeters the height of the effusion from the first rib space where you see the effusion to the diaphragm. And then you measure the depth of the effusion from the chest wall to where the collapsed lung is. And then you multiply that by 70 to give you an effusion volume estimate. And this is thought to have about an 83% accuracy. And this is presented in the Lawson ERJ paper on the statement of thoracic ultrasound. So when we've got a patient with a pleural effusion, we're going to perform a thoracocentesis or diagnostic tap. And it's always very tempting to go posterior when we want to tap in effusion. However, the intercostal artery is a direct branch of the descending aorta. And we're told at medical school that the neurovascular bundle runs under the rib. But in fact, posteriorly, the intercostal artery can be directly in the middle of the intercostal space. It has a variable location. It's only when it reaches the lateral border of the rib does it run under the rib. So that's why we say that all pleural procedures should take place in the triangle of safety, because you know the neurovascular bundle runs under the rib. And you can see from this angiogram here that the intercostal artery actually is not under the rib, it's right in the middle of the intercostal space. And generally you should avoid posterior approaches, certainly within 6 centimeters of the spine, because that's where the greatest risk is and where the intercostal artery is most likely to be punctured. There are a nice couple of papers here which shows that the intercostal artery has a variable location in the intercostal space, and that you should probably screen for intercostal vessels prior to performing any pleural intervention. And this can be easily done for those of you who perform curvilinear ultrasound on a regular basis, because you'll have a Doppler mode on your machine. So here you can see in this diagram that, in this photo, that we've got a curvilinear probe. And what the operator is doing is you're scanning an intercostal space perpendicular to the chest wall, but then you do a fanning technique. So you fan downwards into the intercostal space and upwards. And you put the Doppler mode on, and you're looking to see where the intercostal artery is. Is it inferior, in the middle of the intercostal space, or superior? And you can see on this image, it's a curvilinear probe. You put the Doppler on and you get this box forming around the area of interest. So remember, it's the subcutaneous tissues here. And you can see where the intercostal artery is and maybe where the vein is. And you know that if you go in the middle here, if you go in the center of this, you'll reach your effusion safely and not puncture. And then hope puncture intercostal vessel effusion in the middle, the anechoic area. There is the lung, visceral pleura, and the parietal pleura is thickened. When you put the Doppler on, you think, okay, I'll go into this area and tap the effusion or do a pleural biopsy potentially. But when you put the Doppler on, you can see that the intercostal artery is directly there. So you probably want to abandon this procedure. So there's a risk of intercostal bleed. Once we've put a chest drain in under ultrasound guidance for malignant pleural effusion, you want to perform pleurodesis. And we know that talc pleurodesis using steri-talc has about a success rate of about 75 to 80%. And then pleurodesis is the management choice in over 3/4 of malignant effusions. So according to the BTS, we only want to perform pleurodesis when less than 150 mils of fluid has drained in 24 hours. So once that's happened, you'll perform your talc slurry pleurodesis, and then you'll remove the drain once less than about 250 mils is draining in 24 hours and that there's radiological improvement. Now, there has been a nice observational study which showed that if you perform thoracic ultrasound scans after you've performed pleurodesis, you see lack of lung sliding sign, then that predicts pleurodesis success at 1 month. I'd also say that you probably want to perform a thoracic ultrasound scan before you do pleurodesis as well, to ensure that the pleural cavity is as dry as possible. But using ultrasound after pleurodesis and seeing lack of the lung sliding sign, so that's the pleural stripe, would hopefully predict successful pleurodesis. So when you're doing an ultrasound post-pleurodesis, in this study, what they did was they looked at the anterior chest, in the axillary approach, and posteriorly in 3 areas, the upper, mid, and lower zones. So there's 3 on the front, 3 in the side, and 3 posteriorly. So 9 areas, and they look for lung sliding. So you can see here the pleural stripe, and that should be moving normally. But if there's a point where you no longer see the pleura moving, then that's the area where pleurodesis has happened. It's called absent lung sliding. And they gave a score in these 9 areas of whether lung sliding was present, questionable, or absent. So in the study called the SIMPLE study, which is about 300 patients over 10 centres in the UK and 1 in the Netherlands, they randomised patients through the standard care pleurodesis or ultrasound-guided pleurodesis care, and they looked at length of stay. And they found that if you had a lung sliding score of more than 20, so indicating successful pleurodesis, the drain was removed. And they found that this reduced your length of stay by at least 1 day, and they found that perhaps ultrasound should be incorporated into malignant pleural effusion pleurodesis protocols. Similarly, thoracic ultrasound can also be used as a predictor of pleurodesis success once you've administered, when you're thinking about taking out an indwelling pleural catheter. I know these aren't available in Sri Lanka at the moment, but it's the same analogy. So moving on to non-expandable lung. So non-expandable lung, also known as trapped lung. So this is where you've got visceral pleural thickening. So there's a fibrous band along the visceral pleura preventing the lung from re-expanding, or there's a proximal endobronchial obstruction preventing the lobe from re-expanding. Naturally, a trapped or non-expandable lung is a contraindication to pleurodesis. And here, perhaps an indwelling pleural catheter might be more effective. You can see on this sort of thoracoscopic image that the visceral pleura is studied with tumour. And there's a thick rind seen on the CT. But sometimes we often don't know if a patient's got trapped lungs. So you can see in this patient with a right pleural effusion, a chest drain was inserted. He had a malignant effusion, and then the plan was to perform talc pleurodesis, but the lung is trapped. You can see that lung's not going to re-expand. So we had to take the drain out and let the effusion reaccumulate and insert an indwelling pleural catheter. But surely it'd be good to be able to predict whether someone's got a trapped lung so that you put an indwelling pleural catheter in and avoid a chest drain. And there has been some interest in pleural manometry. So this is a digital manometer which attaches onto the end of your introducer needle when you're entering the pleural cavity. And in normal lung, the pleural pressure should drop very gradually, as you can see on this green line. Okay, so as the effusion is drained, the lung will slowly re-expand and the pleural pressure will drop slowly. However, when the lung is trapped partially or fully, the lung is not re-expanding. When you put a needle in and you put the manometer in, the pleural elastance pressure drops much, much more rapidly and you get a negative pressure quickly. And when you see this on a manometer, you might think, well, this patient's got a trapped lung and perhaps they might benefit from an indwelling pleural catheter rather than a chest drain. This has been evaluated by Kevin Blythe's group in Glasgow, where it was a feasibility study where they randomized patients once they enter the pleural cavity using a catheter and attached a manometer to it. And they found that if the elastance was more than 14.5 centimeters, then the patients like to have a trapped lung and it had an indwelling pleural catheter inserted. But if the pleural elastance was less than 14.5 centimeters, the lung was probably likely to re-expand and the patient benefit from a drain and talc pleurodesis. So you can see here, in this patient with the right pleural effusion, the pleural elastance dropped much more gradually compared to this patient with the blue on the blue graph, where it dropped much more rapidly, and they had a trapped lung. However, ultrasound can also be beneficial. So here, in picture A and B at the top, you've got a patient in picture A with a right pleural effusion, and in picture B with a patient with a left pleural effusion. So on B mode ultrasound, you can see that this patient's, there's got an anechoic effusion, there's a diaphragm, and you can see the lung in the middle. It looks like a reversed hockey stick or J-shaped. And when you do M mode ultrasound, motion mode ultrasound, you're looking for transmission of the cardiac impulse through the lung, and you can see this sort of poor transmission, and that implies that the patient is likely to have a trapped lung because the lung is not transmitting the cardiac impulse through it. However, in a non-trapped lung, on B mode ultrasound, you may see a fishtail sign with an anechoic effusion, and you can see the cardiac impulse transmitted through that non-trapped lung with a dicrotic notch. But obviously, M mode ultrasound requires a lot more experience and training, but it does have its potential use in predicting trapped lung. Let's move on to image-guided pleural biopsy. So ultrasound-guided pleural biopsy is an alternative to thoracoscopy or a CT-guided biopsy. It can be done at the bedside under real-time guidance. It's quick, and it obviously involves no exposure to no radiation, it's not very as invasive as thoracoscopy. There's a nice study here published by Nagaraman in Respiration 2021, which showed that there was no difference in the diagnostic yield between an ultrasound-guided and a CT-guided pleural biopsy. And of course, you can use it for malignant pleural thickening, but also infections such as TB. And obviously, it depends on the extent of the pleural disease. Is it localized or is it more diffuse? Obviously, if it's more diffuse, it's probably easier to do a ultrasound-guided pleural biopsy. But there's no real data on use of Abraham's versus a core-cutting needle biopsy. So you can see here, using a curvilinear ultrasound probe with a sheath, you've got a Temno cutting needle, and by putting it at the angle, you can see where it's entering. So you can see here, these are the arrows where the needle is coming in. There's infusion and there's some pleural thickening. You can see the needle's coming in at an angle on this curvilinear probe right into the pleural thickening. Obviously, it's easier to see the pleural thickening on ultrasound when it's more than a centimeter. And I think it can be quite difficult to delineate where the parietal pleura is with the presence of an effusion. Similarly, if you see pleural nodularity, it's much easier to visualize the parietal pleura. How about image-guided lung biopsy? Well, similar to CT-guided pleural lung biopsy, ultrasound, again, no radiation, and it's quicker. And if you've got a very peripheral mass in the lung, which is adjacent to the chest wall with no aerated lung nearby, so you've got the mass in contact with the visceral pleura, under real-time ultrasound guidance, you can biopsy it again, and the diagnostic yield is supposed to be quite good. On ultrasound, you can see here on the CT image on the left, you can see the patient got an effusion with a very peripheral lesion in the lung. When you do the ultrasound, you can see the anechoic effusion and you can see the mass, and that is a bit necrotic, but under ultrasound guidance, you can enter this, and obviously it reduces your risk of pneumothorax significantly. Again, when you put ultrasound, you can put Doppler on to see if there's very highly vascular areas which you want to obviously avoid due to risk of bleeding. Moving on to pleural infection. So we'll all be dealing with parapneumonic effusions and empyemas, and there are three phases to an empyema. You know, there's the exudative phase, where it's quite easy to drain the effusion. There's the fibrinolytic purulent phase, where you start getting the complicated turbid effusion and empyema. And then the organized phase, when you start getting multiloculated collections with fibrinous strands. And the beauty of ultrasound is that unlike CT, where you might see a split pleural sign, you can see all of these different phases potentially on ultrasound. So you'll often may have a chest X-ray which shows a lenticular collection. So it looks like a lens. So in the correct clinical context of someone who's presenting with symptoms of pneumonia, if you see an X-ray with a lenticular collection, you may do a CT scan and see the split pleural sign as the visceral parietal pleura come away, and you should always think that patient might have an empyema. But when you do ultrasound, you can see that it's a complex, homogeneous echogenic collection here. You can see it's very similar to the liver here. So this is probably like to be quite thick, highly proteinaceous material. But then you start developing fibrin strands, and then it starts getting quite organized, and you get multiple loculations. Now, when you see this sort of collection on an ultrasound, you know that even if I put a chest drain in here, it's not going to decompress all of this. So if you put a chest drain in this first image on the top left, you'll probably get a successful outcome. But if you put a chest drain in one of the two images at the bottom in a multiloculated collection, you're not going to get a satisfactory outcome. However, our thoracic surgical colleagues often don't appreciate this, and that you can't see it on CT. So when you've got this sort of collection, you may still put a drain in, and you may think, well, patient's going to need surgery or may benefit from intrapleural fibrinolytics. Now, there is the MIST-3 trial which has been going on, looking at early intrapleural fibrinolytics versus early surgery for patients with empyemas and potentially septated collections like this. So I'm just going to show you a couple of videos here. So you can see on this ultrasound image of this patient, there is the diaphragm, and you can see the liver here, and there's some multiple septations here. So these are floating around and haven't become quite organized yet. Putting a drain in here will hopefully try and decompress a lot of this, or if you're going to do a thoracoscopy, you should hopefully be able to break some of these down. In the ultrasound image on the right, you can see there's all this proteinaceous material swirling around. There's quite a thick fibrous septation developing here, but again, hopefully drainage should be successful, or even at thoracoscopy, you should be able to break this down. So the audio study was a feasibility study looking at the role of pleural biopsies in pleural infection. Most of our treatment in pleural infection is based on broad spectrum antibiotics. In about 40% of cases, we don't identify a reliable pathogen. So in this study, they had 20 patients with pleural infection, and they underwent an ultrasound-guided pleural biopsy. And at the same time, they had samples sent for pleural fluid culture and blood culture. And they wanted to see if pleural biopsy increased your microbiological yield. So they used an 18-gauge Temno needle like here with a 2 centimeter throw. So it's deployed into the pleural cavity about 2 centimeters. And they wanted at least a 3 centimeter effusion area to be safe that you didn't hit the lung. Pleural thickening was not necessary, and they took 6 to 8 biopsies. And they found that the ultrasound-guided pleural biopsy increased the microbiological yield by 25% compared to pleural fluid or blood alone. Excuse me. So you can see that here. These were the most common organisms found. Naturally, Streptococcus milleri is very common. In pleural infection, it prefers the nice anaerobic environment in which to thrive. And you can see there was a 25% improvement, microbiological culture improvement compared to pleural fluid or blood cultures. And it's thought that microbes are going to be likely in the parietal pleura because it has a blood supply, hence better nutrition, unlike the pleural fluid, which is a hypoxic, acidic environment which lacks nutrition. So let's move on to pneumothorax. So ultrasound can be used to identify an iatrogenic pneumothorax following a CT-guided lung biopsy, for example. And you can use both B-mode ultrasound to look for the absence of the lung sliding sign to indicate a pneumothorax, and also the M-mode ultrasound to look for what is known as the stratosphere and seashore sign, and I'll talk about that briefly. But obviously, ultrasound has limitations in pneumothorax. It's a binary test, so it's only going to tell you, well, is a pneumothorax present or not? You have no idea of the size of the pneumothorax. And it can be difficult when the patient's got an underlying lung condition like emphysema, or if there's bully there, or if the patient's had pleurodesis, and it's, for example, a loculated pneumothorax where the lung is tethered to the chest wall and there's a small pocket of a pneumothorax. So, ultrasound image, what I've got for you is on the top, there's a patient with no pneumothorax, and at the bottom, there's a patient with a pneumothorax. And we've got B-mode ultrasound in the middle, on the left, and M-mode on the right. So in B-mode ultrasound, in a patient who doesn't have a pneumothorax, you'll see the normal lung sliding signs. As the patient breathes in and out with respiration, you'll see the pleural stripe moving in and out. So there's no pneumothorax there, okay? If the pneumothorax is present in B-mode ultrasound, okay, what you will see is multiple reverberation artifacts here, okay? You'll see all these lines, and the pleural stripe will not be moving, so you'll see no absence of lung sliding sign. Okay. Now, if you switch to M-mode ultrasound, motion ultrasound, then in the superficial structures of the skin, the dermis, the fat, the intercostal muscle, you've got a static area here, remember? So that's what they call this a seashore pattern because that represents the sea, the subcutaneous structures. And remember, the lung transmits ultrasound poorly, so you'll see the pleural stripe, and below it, you'll see sort of this sandy area. So they call it the seesaw sign because the top part, the subcutaneous structure, is the sea, and the sandy area is where it's more granular, and you see lung sliding sign. When you have put the ultrasound in M mode for pneumothorax, you will not see this seesaw sign where there's sort of, you'll see this barcode pattern where there's multiple lines with no lung sliding. It's quite a difficult skill to acquire, and I think obviously ultrasound for pneumothorax is only when you've probably been doing it, you're doing it on a regular basis and you've got more advanced skills in ultrasound, so it's not routinely performed, I think. but I'm just it gives you, it's just explaining the utility of this. So how about medical thoracoscopy? So we will always scan the patient with an ultrasound with them sat up, but we perform medical thoracoscopy in the lateral decubitus position. And when the patient's in the lateral decubitus position, the fluid sort of dips, moves anteriorly and posteriorly, and there's less fluid in the mid-axillary line. So we will probably use a Bhutan needle to try and induce a pneumothorax. Now, when you're concerned that there is not much fluid present or you're not sure where the lung is, you can do the B mode ultrasound using a curvilinear probe, and you can see here in picture B, there's the visceral pleural with a bit of fluid behind it. You can then, under direct guidance in picture C, introduce your Bhutan needle, okay? And you'll know that you're not going to go far too deep, you're not going to hit the lung, but you're doing it under live guidance, so you can see where the Bhutan needle is, and then you can stop. And once the Bhutan needle is in a safe position, you can allow air in. So now, under live guidance, you should be able to see that as air goes in, you see lack of lung sliding because you're inducing a pneumothorax. However, if the lung doesn't go away, then there's reduction or absence in the normal lung sliding sign, and that might imply that there's pleural adhesions. So if there's pleural adhesions present, and when you put the Bhutan needle in, you're not able to induce a pneumothorax, you probably want to avoid doing a procedure and considering that patient for referring that patient to your surgical colleagues for a VATS. So how about lymph node sampling? So I think we're much better at identifying lymph nodes using ultrasound now because there's widespread use of EBUS for mediastinal and hilar nodes. However, bedside ultrasound scan can also be used to identify, for example, supraclavicular lymph nodes. So if patients have got cancer on their CT and there's a suggestion that they may have supraclavicular lymph nodes, so N3 disease, you could use the ultrasound and identify a node and do a true cut biopsy. Normally, you probably want to use a linear probe, which is high frequency. Remember, it gives you much better resolution of superficial structures. And again, with experience, you might be able to tell nodes which are benign or pathological. A benign node might appear more ovoid or triangular with a fatty hilum like it can do at EBUS, whereas a pathological node might be larger, there's no hilum, it looks more necrotic and it's irregular. And you can use a fine core cutting or true cut biopsy, and obviously it avoids the patient having a surgical biopsy or potentially a more invasive procedure like an EBUS if you wanted to avoid it. So you can see here, this is a superficial node, so you can see the capsule around the node. When you put the Doppler on, you can see there are a few blood vessels around, whereas in this node here, you can see the vessels are sort of more distal, and you know that if you go into this needle into this node under direct guidance, you'll be able to get a satisfactory sample. So here you can see, here's the lymph node, and with these arrows indicate where the needle's coming in at an angle, and then obviously vessels around it, the jugular vein, the carotid here. So how about future directions? So there's interest in contrast enhanced thoracic ultrasound, or CTS. So what does contrast enhanced ultrasound offer over conventional ultrasound? Well, if you administer contrast, you might be able to get some information on the microvascular structure or the blood perfusion to the lesion or the mass of interest. And by using contrast enhanced ultrasound, you may be able to see disease activity and separate it from necrosis and identify viable tissue compared to necrotic tissue. So here you can see there's in picture A, there's the pleural stripe, and then you can see this pleural base lesion. And initially you think, okay, this is fairly straightforward to biopsy under direct guidance. When you do contrast enhanced ultrasound, you can see that there's a necrotic area in the middle. And perhaps if you were to put your needle straight into there, you may not get much satisfactory tissue, but you might need to go a bit more laterally. And there's a nice systematic review published earlier this year, which that contrast enhanced thoracic ultrasound was able to increase your diagnostic accuracy of ultrasound guided pleural mass biopsies by at least 15% compared to conventional ultrasound. There's also interest in ultrasound elastography. So elastography is also used in EBUS, and it looks at the stiffness or elasticity of different solid structures. Okay, so the elasticity, if the structure appears very stiff or hard, then that's likely to be malignant. But if the tissue appears quite elastic and soft, then it's likely to be benign. So here you can see on this tissue ultrasonography, looking at elastography, there's a pleural-based nodule which looks quite oblong and flat. And then when you scan further along, you can see there is pleural thickening here. So this is the parietal pleura here, which is about 1 centimeter thick. And when you put it onto the elastography mode, you get these different color densities. And the dark blue areas imply soft tissue, which is benign, whereas the red implies stiff tissue, which might be malignant. So again, you can direct your biopsy to the area which you'll hopefully get more information from. So in summary, we've gone through the utility of ultrasound to identify effusions, which is what you'll commonly be doing, and how you can do pleural procedures safely, how it could be used to identify trapped or non-expandable lung, that you can perform image-guided pleural biopsies provided you've got an effusion present and at least perhaps 1 centimeter thickness of pleural, a parietal pleura, essentially when you're learning the technique, and also peripheral, very peripheral lung masses which are in close contact with the visceral pleura. You can do image-guided parietal pleural biopsies in infection, and we know you can see it increases the yield. There's a role for it in pneumothorax, perhaps particularly in an ITU environment where the patient's intubated and you put a central line in, and you're worried as the patient got a pneumothorax, you could put an ultrasound on and put it in B or M mode, well, M mode, and see if there is lung slide, if there is a seashore sign or the barcode or stratosphere sign. It should be routinely performed before you do thoracoscopy, so to see where the fluid is and where the lung is present, where the lung's tethered to the chest wall. And you could also introduce your Bhutan needle under direct guidance. And you can be used for superficial lymph node structures as well to avoid more invasive biopsies. In terms of risk, an excellent ERS thoracic ultrasound monograph written by Christian Lorson and Naj Raman, and also an excellent book with lots of images and a guide to an ebook which gives you access to lots of ultrasound videos and images written by Gary Lee's group, and I know he's also presenting at this webinar. I've put these references up again. These are freely available to download if you search for them on PubMed, and they'll give you a nice introduction to ultrasound and what you should be looking for. Thank you very much. Happy to take any questions.
Thank you very much, Dr. Vanchal. Very interesting presentation. And you actually updated us on thoracic ultrasound and intervention, as well as the current, what is new in thoracic ultrasound. We will have a question and answer session at the end of the presentation. And we will move into the third presentation, management of pneumothorax, a new horizon, by Drs. Afla Sadikin, the consultant respiratory physician attached to the Colombo South Teaching Hospital, Colombo. And Dr. Afla is the council member of Sri Lanka College of Pulmonologists, and he will go to present the what is new and the new horizon of our pneumothorax. Dr. Afla Sadikin.
Thank you very much for your kind introduction, sir. And first of all, I want to thank the chair of Pleural Assembly of College of Pulmonologists, Dr. Dushanta Madhara, for giving me this opportunity. And also it's a privilege to sit with and to discuss in this forum among the high-profile people in pleural disease. So today my talk is on pneumothorax management. So it's a common scenario, it's a common clinical condition, it's a common clinical challenge we get in the day-to-day practice. So in my next 20 minutes or so, I'll be talking about the current guidelines, how we apply for our management of our patients, and also what are the current evidence we have in case of managing those patients in the different clinical situation. Also, I'll just touch upon about ambulatory management, ambulatory devices. Of course, it's not something new, though it is evolving, but it's an old approach. and also a little bit on air leak and in pneumothorax also would be discussed. So let's start with the case scenario. A 37-year-old male admitted with a history of chest pain, and so now in the emergency, in the outpatient department or in the emergency department, you always want to get a chest X-ray, and especially when you have excluded any sinister pathology like cardiac pathology. And then you see this in this chest X-ray where the radiolucency in the peripheral with the clear lung margins and with no lung markings in the radiolucency area. And so when you see a patient like this, you want basically to manage in an optimized way by the best possible manner. However, when you look at management of pneumothorax, you have quite a few options. Like now I have given 6 options. So when you have quite a few options in a scenario like this, so we tend to go a little away from the guideline or the best possible option we can give it to this patient. So this is a nice survey done by Rob Halifax and the group in UK. So this is supposed to be one of the first survey of pneumothorax practices in UK, across in UK. So what happened? It was an online survey basically across UK, and they found that both primary spontaneous pneumothorax and secondary spontaneous pneumothorax were managed in a very contrast way in certain situations. As an example, if you take the primary pneumothorax, spontaneous pneumothorax, which is a large one, there is a group of people who would like to do a needle aspiration, and there is a group of people who would just do a conservative management by observation. Also, when you consider the large primary spontaneous pneumothorax with symptoms, and there's again some people would go for a chest drain initially, and some people would go for a needle aspiration. So this kind of contrast management approach will definitely can give some kind of confusion in the clinical practice in a emergency situation. So we have a very old guideline. Basically, the British Thoracic Society's guideline was published in 2010, and the ERS is in 2015. So I'm sure it's in the pipeline of updating it. So if you look at the management, it depends on what type of pneumothorax we are dealing, and also, as I mentioned before, the physician's preference. And also don't forget the resource availability and the capability of the person who is doing the procedure. So looking into this context, we know that there are some parameters we need to consider before deciding on the exact management plan. So one thing is we discuss about the type of pneumothorax. I will go into detail in the next few slides, and the size of the pneumothorax. So basically, the American guideline is always, Americans are, we know that something always little different, and basically they consider as a large when there is apex to cupula distance is more than 3 centimeters. However, according to the BTS guideline, you have to have the measurement at the level of hilum, where your lung margins and the chest wall is more than 2 centimeters. Also, it is important to emphasize on the severity of symptoms before you decide on the exact management protocol. And also it's sometimes it's quite useful, especially to know that whether this pneumothorax is for the first time or is it a recurrence, especially when you decide on the long-term plan and the prognosis. So especially we have not addressed much on this patient's preference when it comes to pneumothorax management. Probably we are dealing the patients in an acute situation where the patients are not given a choice. So I think with time that the practice should be a little different. So especially for pneumothorax in the future. So this old guideline from the BTS, but still it's valid and it's widely practiced. And this one, what important here is to find out the patient's hemodynamic stability. And if when you are so sure that the patient is hemodynamically stable, only you are proceeding to find out whether the primary pneumothorax or secondary pneumothorax. And also it is important to find out whether this pneumothorax is bilateral or unilateral. If you have a patient who is hemodynamically unstable or having bilateral pneumothorax, there is no second word, patient has to go under a chest tube drain. Now, if you look at once you exclude that, so basically the challenge is for you to differentiate whether this is a primary pneumothorax or a secondary pneumothorax. Now, sometimes it's quite challenging at the outset. However, it is important to know that the age distribution also, and because sometimes you may not you may not have a clear-cut diagnosis of secondary pneumothorax beforehand. So they say about a bimodal age distribution where the primary spontaneous pneumothorax is common between age of 15 and 34, and the secondary pneumothorax is quite it's common more than 55 years of age. Why this says is because—
Sorry to interrupt, Afla. Your slides are not moving. Your slides are not advancing.
Not advancing. Oh.
We're still stuck in the first slide with the case scenario.
Oh. Now, what we need to know is after excluding the hemodynamic instability, and if it is not bilateral, what we need here is to look for the primary pneumothorax or whether it's a secondary pneumothorax. So the evidence suggests that the primary spontaneous pneumothorax is common between the ages of 15 and 34, and secondary pneumothorax is common when the age is more than 55. Why? Because when the patients are older, there can be an unrecognized underlying lung disease, and because also the smoking history also plays a big role when we want to differentiate the secondary pneumothorax. So 60% of the times, most of the pneumothoraxes are spontaneous pneumothorax are secondary. Now, once you diagnose this as primary spontaneous pneumothorax, what we should do is to find out the size of the pneumothorax by the previous measurements I have explained. So if it is more than 2 centimeters, and if the patient is not breathless or even slightly breathless, if there is no breathlessness, patient should be considered as an outpatient management. However, if the patient is symptomatic and if the size is more than 2, and you can go for you should attempt for an aspiration with a 16 to 18 gauge cannula. Now, the success rate also is important of the aspiration. If it is successful, and if you say that if it is the repeat X-ray is showing less than 2 centimeters, then of course we can always discharge the patient. And if the patient is not successful after the aspiration, then we must go with the next plan, whether to go for a intercostal drainage. However, now in this flow chart, they say that if you have a large pneumothorax, but still the symptoms are very minimum, still you can approach for the conservative management. So what are the evidence we have for this conservative approach over interventional treatment in spontaneous pneumothorax? In 2017, they have done a Cochrane analysis to compare the aspiration versus drainage, and in that study, analysis, they found that interpersonal drainage was having a good success rate. But however, the statistical power is lacked. But also, again, they said that needle aspiration has less adverse event, and definitely inpatient stay is much less. So the Brown and the team, I'm very happy to say that Professor Gary is with us here. He was one of the key investigators in this study. So in this open-label multi-center trial, basically came up to give a lot of evidence about spontaneous pneumothorax management, where the conservative versus interventional approach. And they put into two groups, and in this study,
I think your slide is stuck again. It's still in the flow chart. Yeah.
So this study basically gave us a clear picture on interventional group versus a conservative group, where the lung expansion in both the groups were quite similar, and it provides most evidence to say that there was no conservative management on the PSP was non-inferior to the interventional management. So, and also they showed that there were the low risk of side events. So this opened up a management option of even large pneumothorax with a conservative approach. So if it is a large pneumothorax and you have the aspiration is failed, or even your observation is failed, you can always straight away go for a chest drain. But if it is a secondary pneumothorax, it is more than 2 centimeters, and then of course is it stuck again? And if it is more than 2 centimeters, you can go for a chest drain. So if it is less than 2 centimeters, you have again an option of going for an aspiration. And if there is less than 1 centimeter, you have no symptoms, you can always go for an aspiration. Right. So this randomized studies, which was published in ERJ in 2015, basically showed us that the aspiration versus chest drain, the number of days you need to stay in the hospital was higher in chest drain group, and it was very clear that the success rate was there's no significant difference between aspiration versus chest drain. So I think now we have got enough data on that. About needle on the needle versus drain. However, Tele and the group did a study which is a randomized control study, because it was or previous studies were not randomized control, and out of 127 patients, they basically as a primary outcome, they checked the duration of hospital stay. And the secondary outcome also, they look at the success rate and the complications. Now, when you look at the immediate success rate, better in needle aspiration, and but 1 week success was no difference. And obviously, there were no complication in needle aspiration. This was the hospital duration, both in primary as well as secondary, was reduced in aspiration group. So let us go with our patient now. So let us go with our patient now, who is a 37-year-old chap with a pneumothorax. And what is the best management? I think now in this case, if the observation with the chest pain, and if the observation is not possible, I think needle aspiration is the first choice. But if it fails, what we need to, and in this case to 50%, and repeat aspiration or intercostal drainage. But anyway, there is no evidence to suggest that second aspiration was chest drain. Now, size of the chest drain has been a debate when it comes to intercostal drainage, but there have been no randomized control studies to show that there is the small bow is going to be preferred over a large bow. So the other question comes, do we have any other management options in this group of patients? If you are looking for a better management option, basically what we need to look at is how we can reduce the hospital admission duration, and can we facilitate these patients as an outpatient treatment, and the discomfort the patient is going to have from large test tube, can we reduce that, and also how can we keep this patient mobile and to facilitate for an early discharge. Obviously, the cost effectiveness also should be considered. But nevertheless, it is important for us to know that whatever the option we are going to offer for these patients, we need to have good evidence for good efficacy and for safety profile. So ambulatory management of spontaneous pneumothorax was not something new. It has been even published in thorax few decades ago, and especially using this Heimlich flutter valve. But the current BTS also says that it can be used with a Heimlich valve in certain selected cases. However, we see these few options of ambulatory management for ambulatory management in pneumothorax by using this certain valves and devices. So the common one is Heimlich. It has been used in the past, Heimlich valve with chest drain, but the pleural vent has been now studied a lot, and there are, I'm sure, in England and in Singapore and Australia also, they are using quite now the pleural vent. Now, if you look at the studies or the evidence what we have on ambulatory management options, the RAM study, which was a randomized controlled trial, which was done over many centers, and at 30 days, they have found that receiving this ambulatory treatment had, literally none of them stayed in the hospital, and the standard care people average they had to stay for 4 days. But the adverse events, but when we look at the adverse events, there was the ambulatory care patients had higher adverse events, and out of which all the 14 serious adverse events were in that group. So let us go for this case, who is a 48-year-old smoker who is coming with a shortness of breath and diagnosed to have pneumothorax. And looking overall, he's looking at his chest X-ray. The diagnosis of the secondary pneumothorax was done, and the chest tube was placed. After 24 hours, he is now hemodynamic stable, but the chest drain is still bubbling. So what is the next option we have? So what we know here now is this patient is having an air leak. So what the recommendation says is, once you look for the air leak after 24 hours, at 48 hours, if the leak is still present, patient we have to discuss with the surgeon. So I really don't know how important it is to discuss every patient after 48 hours. But however, what it says is, if the leak is more than 5 days, then of course we have to consider this as a persistent air leak. Now, why the persistent air leak? It caused by the alveolar pleural fistula or even bronchopleural fistula. It may be different, clinically differentiate at the outset. However, having a persistent air leak itself will increase the morbidity, and also, especially in ventilated patients, the mortality can go up to 67%. Now, this article is quite interesting, though it is a little old, and it's in this study, what they looked at was the duration and the resolution of air leak in those patients who are having the chest tube. And interestingly, on day 7, both in primary spontaneous pneumothorax and secondary pneumothorax, spontaneous pneumothorax, their resolution was 75 and 61% respectively. And at the end of 14 days, the primary spontaneous pneumothorax had a complete air leak resolution in 97 patients. 97 patients. 97. So that shows that the duration of the air leak basically we will decide the complete resolution of in the pneumothorax. So what we have few options in case of persistent air leak, where we can continue with the chest drain, looking for that duration for complete resolution, or even we can apply the suction, or we can use a chemical pleurodesis. And there have been some studies done on autologous blood patch, but also the interventional approach with endobronchial and intrabronchial valve is also being used in many centers. However, all these things after 48 hours, we must get the surgeons involved for their opinion. And finally, because the surgery is one of the best option, and we can't wait for the patients, because these patients are invariably unwell sometimes, so you can't wait for them to be unfit for surgery, especially when you detect the air leak at the beginning. So we have the options at that time. You can put a second IC tube that some surgeons will prefer, and you can continue with the suction, as I said before, and the observation is another for duration of that time for the patient. Now, so to predict the air leak, there's no standard method. However, that the evidence are there for quantitative measurements of that airflow by using a digital suction device. So if you can have a measurement for an absolute flow rate, and by this digital suction device, basically you can potentially predict the future treatment failure. So, however, the high risk of failure is something need to be detect early, rather than keeping for observation for a long time for early thoracic surgery. So this patient who came with shortness of breath, who is a 64-year-old gentleman who came, who had a kidney transplant 4 months back, and he had a left-sided pneumothorax, and he had saturation dropped to 94, and then subsequently went down to 88. He had to undergo an immediate chest drain, and with the chest drain, his symptoms are improved. And when we did the CT scan, this was the CT scan where he had the cavitary, intracavitary bodies also, both the lungs, and there's subcutaneous emphysema. So with this, we had to continue with the IC tube, and the persistent air leak got slowly settled, and the surgeon did not want to operate or do any kind of intervention immediately. So it shows that observational approach by waiting for a persistent with the persistent IC tube is an option for these patients for the better outcome. So what we can look for is an updated guideline, and also we have to think of a new pathway for these spontaneous pneumothorax patients, especially for the primary spontaneous pneumothorax patient. And our approach has to be a patient-centered approach, and most of these patients can have an observation as a first option, especially with the evidence what we have. And if we can create a safety nets as in those appropriate patients, even those patients can be managed as outpatient, especially using as an ambulatory management option. So, but the ideal management still is debatable in secondary spontaneous pneumothorax. So in summary, so we need to understand the conservative approach is not inferior to interventional approach, and the needle aspiration is the first line of management in most of those patients when it is appropriately selected. And though the ambulatory management is considered as new, but it's not something new, but the newer approach for the patient selection is something very important. When it comes to the persistent ARE, what we need to understand is if you can have a risk stratification to detect early, those patients will have a better outcome. So what we need is a model to individualize the management. Thank you. I'm really sorry. I think my slides were all over.
Dr. Afra Sadikin, for your lecture. In the interest of time, we will move on to our final lecture. The speaker is Dr. Anandam Devanand from Singapore. He's a consultant respiratory and critical care physician at the Singapore General Hospital, and he's also the head of the SingHealth Duke NUS Lung Center. Dr. Anandam will be speaking on the management of complicated pleural effusion with an emphasis on malignant pleural disease. Over to you, Dr. Anandam.
Right. Thank you. Thank you very much for that kind of introduction. I presume you can see my slides. So thanks once again to Damit and Dushanta for the kind invitation. I hope to be in Sri Lanka soon in person. I've always had very happy memories of visiting. And it is quite an honor for me to be here today to share a panel with Gary, Rakesh, and Afla for their really incredible insights. Some of the things that I will cover will revise some of the topics that Gary and Rakesh have already covered. Okay, let me get my slide going. So my slides, as usual for our lung center, have been posted on Facebook. So if you want a copy of the slides, they are available. They're already up there in the SingHealth Lung Center Facebook, and together with the slides of all our other talks as well. I also want to make a quick disclaimer. It's always challenging to have Gary Lee in the panel because so much of the data that I will present is from his group, but I will do the best I can. All right, so moving on, malignant pleural effusions, right? So definitionally, malignant pleural effusions are essentially effusions in which there's malignancy in the pleural space. And this is distinguished from paramalignant effusions where the pathophysiology is different. It is associated with malignancy, but there's no direct neoplastic involvement. This can be due to pulmonary embolism, airway obstruction, drug reactions, and so on and so forth. So to illustrate the talk, I will introduce a typical patient of mine. She's a 60-year-old Chinese lady with no significant past history. She's a non-smoker. She presents with progressive dyspnea. And interestingly, she's tachypneic without being hypoxic. And it's important to think about why this patient would be would have dyspnea without actually having hypoxia. And that's where the pathophysiology of pleural effusions is important. So yes, large pleural effusions will cause some compressive atelectasis of the lung, and that will compress part of the lung. But the other things that the pleural effusion will do is it will press down and weigh on the diaphragm, and that will increase the work of breathing. And it will push outwards on the thoracic cage and place the rib cage at a biomechanical disadvantage. So that means that if we can drain the effusion even without improving hypoxia, we can provide symptom relief. So it's typical for pleural effusions to correlate, just for symptoms of pleural effusions to correlate poorly with size. And this is because dyspnea depends on cardiopulmonary reserves, which in turn are dependent on comorbidities and other cancer complications of the lung, such as lymphangitis and endobronchial obstruction. So quickly with diagnosis, so this patient has got an exudative effusion on all 3 limbs of Light's criteria. For malignant effusions, we do a lot of pleural fluid cytology, and as Gary mentioned, 50 cc is more than adequate. There is some utility in sending repeat samples if the first sample is inadequate. Pleural fluid cytology is also dependent on the underlying histology. And at this point, I want to just make a plug that when we diagnose malignant pleural effusions, we must make sure that we get adequate tissue for complete molecular workup, because patients with targeted receptors which can be targeted by tyrosine kinase inhibitors or immunotherapy and so on do have an improved prognosis if they are provided with that therapy. The other issue that Gary also highlighted is the role of cell-free DNA, and that's currently being validated at our center. You can also get a histological sample. Blind histology in malignant effusion has got a poor yield, as Rakesh pointed out, and this can be improved by using radiographic guidance, either via CT or ultrasonography. And then, of course, there is fluoroscopy. Let's hope it plays or not. And one of the things that we've been doing at our center is we've been doing reflex molecular testing for all our patients who've got lung cancer, especially non-small cell lung cancer. And it's been shown that reflex testing for all patients, rather than sequential testing for mutations, results in a faster onset of treatment, and 2, actually it results in some cost savings. The other point of interest that I want to point out to you guys is that for patients with advanced disease, you can see a minority of our patients these days are getting systemic chemotherapy. Most of them are getting targeted therapy or immunotherapy. And this has resulted in an upward push in the prognosis of all stages of lung cancer, including, of course, malignant effusions, which are stage 4 lung cancer. So it is important to treat the underlying cancer as well. And as pulmonologists, we need to provide the necessary molecular workup so that the oncologist can start that kind of treatment. So how do we manage malignant effusions? Well, conventional wisdom will put you at 2 poles because this is advanced malignancy. One line is to wait for substantial symptoms before intervention is done for palliation, and the other is to intervene early to prevent complications like lung entrapment and inoculations. And I'll talk a little bit about this when we see the latest guidelines. But either way, we should do large volume thoracentesis to see if symptoms improve, because if they don't, there could be other causes of the dyspnea. Remember, patients with malignancy and an effusion can have other causes of dyspnea like lymphangitis, airway obstruction, and so on. And just to illustrate this, this is a patient who had malignant mesothelioma. He came in with worsening dyspnea. He's got a moderate sized right-sided effusion. And the question is whether or not we should insert a chest drain. Of course, in a patient with a mesothelioma, he probably had an effusion before. We should look at the old x-rays. If there's no increase in the size of effusion, we should look for other causes of dyspnea. In this case, it was a pericardial effusion. A quick note on prognostication of malignant effusions. This is linked in a strong way to the underlying histology. And of course, this data preceded the use of tyrosine kinase inhibitors for EGFR mutant lung cancers. Right? Of course, multi-dimensional prognostic scores are more accurate than unidimensional prognostic scores. This is the lens score, which is tumor type, the patient's effort tolerance, a measure of the burden of tumor in the pleural space, as well as systemic inflammation to risk prognosticate into 3 groups. There's also the PROMISE score, which involved whether the patient had previous chemotherapy, radiotherapy, what the hemoglobin level and white cell counts were, the C-reactive protein, the functional status, and the type of malignancy. And of course, there's a biological variation of the PROMISE score, which includes the tissue inhibitor of metalloproteinases from the pleural fluid. And this can stratify the patients into 4 groups. But for our patients, we found that these prognostic scores have not been very accurate. There have been attempts to do a modified version of the lens score, which has somewhat improved this. We have looked at our own data, and based on a retrospective review of our data, we have come up with a select score, which is based on the gender of the patient, the functional status, the peripheral leukocyte count, whether there's EGFR mutation or not, previous chemotherapy, and the tumor type. And as you can see, this score performs very well in our patients, better than the LENT and PROMISE, and we are in the process of currently validating this prospectively. For malignant mesothelioma, there isn't a particular score. Rather, there is a decision tree that's available, and this is based on whether the patient has got weight loss, what the hemoglobin is, the functional status of the patient, the albumin score, and the underlying histology. And based on this, we can risk stratify the patients into 4 groups in order to identify the prognosis. So coming back to my patient, the question now is, how will we treat this patient? Nalina, do you want to launch the poll for everyone? Right, so all of you can get to poll, and it'll be interesting to see what all of you choose to manage this patient. I'm sorry you didn't get to see the thoracoscopy image. Maybe we'll give another 10 seconds. 5, 4, 3, 2, 1. Nalina, you want to close the poll? Shall we show it to them? So there's a spread of responses. 10% wanted to do repeat pleural drainage. 50% suggested doing chemical pleurodesis with TALC. 40% suggested indwelling pleural catheter, and nobody went for surgery. So we'll talk a little bit about this. Thanks, Nalina. So there have been 2 relatively recent guidelines for the management of malignant pleural effusions. The first is by the ATS, which came up with 7 broad statements. First, to use ultrasound to guide pleural interventions because that reduces the risk of complications as well as increases the probability of success. Not to perform on pleural interventions in asymptomatic patients because the role of pleural interventions is largely for symptom relief. So it wouldn't make any sense to do this on asymptomatic patients. Then, as we mentioned before, perform large volume thoracentesis to assess symptomatic response as well as lung expansion. So if you do have an expandable lung, then you can use either an indwelling pleural catheter or chemical pleurodesis. And if you're doing chemical pleurodesis, you can use either talc poudrage or talc slurry. If the lung is non-expandable, then IPC or indwelling pleural catheter is the option of choice. And if the IPC gets infected, we treat them with antibiotics, and you don't necessarily have to remove the indwelling pleural catheter. The ERS has also came up with a series of guidelines, and this was framed as a series of questions. And the first question is perhaps the most, the most encompassing question of all. What is the best definitive treatment for patients with symptomatic pleural effusions? And then, as you can imagine, there was no absolute answer from the data, although the ERS seemed to be leaning towards chemical pleurodesis. But The points that they stated as facts were that talc fluoridesis is the most effective agent for chemical fluoridesis, and you also should be using graded particle talc size, so that the ungraded talc with small particles tend to embolize and cause more complications. The second is, what is the optimal management for non-re-expandable lung, and that is IPC, which is in keeping with what the ATS suggested. How should we manage septated or loculated malignant effusions? Well, fibrinolytic therapy improves drainage and improves radiology, but does not improve symptoms and does not improve fluoridesis success. And I'll show you the time 3 trial later. And what factors predict prognosis in malignant effusions? And we've talked about some of the multidimensional prognostic tools, such as the Lens score. Should patients with malignant effusions and cancer that is sensitive to oncological treatment receive treatment prior to definitive management? And they say no conclusions can be drawn, and I will touch on this a little bit. But as I mentioned earlier, it is important for us to treat the underlying cancer, because that kind of treatment does improve the prognosis. And then for malignant pleural effusions, do we need histology or is cytology sufficient? And especially for lung cancer, cytology is increasingly sufficient with the use of immunohistochemistry. And then I'm sure we're moving in the direction more and more of cell-free DNA. A quick plug on the need to follow guidelines. This is based on Medicare data from the United States. As you can see, patients who had thoracentesis were divided into 3 groups, and up to 1/3 of these patients needed a second pleural procedure within 14 days. And of those patients, only 1/4 of them had a definitive pleural intervention based on the preceding guidelines, not the ones that I showed you, right? And it has been shown that if patients do not have guideline consistent therapy, what happens is they end up with more pleural procedures, more pneumothoraces, and more emergency pleural procedures as well. So coming back to the question that was posed, what should we do? Therapeutic thoracentesis. Well, I think there's a role for this. I give you an example. This is a 45-year-old with lymphoma. He has dyspnea, which improves with thoracentesis. The lung is expandable, but should we do TALC? And those of you who are astute will know that this patient has got a lymphoma, which in this case anyway, has not had previous treatment. So with systemic therapy, the patient has a very good response. So in these patients, all that may be needed will be a second thoracentesis. So if we're going to do thoracentesis, we should do under ultrasound guidance, as Rakesh has pointed out. The patients who typically get repeated thoracentesis have very poor survivals, poor functional status, or are very responsive to systemic therapy and are awaiting that therapy or already have had that therapy, right? These days we do pleural manometry, and again, Rakesh has pointed out the 3 curves. There are these new devices which help you measure pleural pressures as you drain them. And you know, the pre-EDIT trial did show that the threshold for a non-expandable lung has gone down from 19 centimeters of water per liter to 14.5 centimeters per liter. And they were able to identify the non-expandable lung after draining as little as 300 mils of fluid. The role of systemic therapy. So this is a retrospective data. As you can see, these are patients who had a range of malignancies. The pharmacologically sensitive tumors were either those that had positive or targetable mutations, or hormone receptor sensitive tumors, or they had lymphomas. As you can see, those who did receive therapy, still about 55% of them had recurrence of the effusion, and those who had non-sensitive tumors who didn't get systemic therapy, the effusion recurred in over 75%. So my takeaway from this is we should not neglect systemic therapy, and that should go in as fast as possible, but we shouldn't wait for it. If the patient does have symptoms, we should intervene and manage those symptoms with pleural procedures. Then we have chemical pleurodesis. This just shows you the way that we do talc pudraj in our unit. It's a little old-fashioned, but it gets the job done with a nice spread of talc. I've already shown you what's well-established data about the safety of graded talc for pleurodesis. The Time 1 study has shown us that post-thoracoscopy, the use of large bore tubes had a slightly better pleurodesis rate than those who had small bore tubes. And this was thought to be related to either the blockage of tubes or the small tubes or dislodgement of those tubes. Time 1 study also showed that we can use non-steroidal anti-inflammatories as analgesia post-pleurodesis. Conventional wisdom has always favored pudraj over slurry, and I've taken this from one of the great textbooks that I learned thoracoscopy from. It has been thought that pudraj allows you to visualize the lung, to do an estimate of how expandable the lung may be, to ensure that the talc is evenly distributed across the pleural space, and to optimally place chest drains. However, the TAP study is the latest study to show that the pleurodesis success rate between slurry and pudraj is equivalent, and there isn't a big difference in the complication rate either. Again, Rakesh has mentioned earlier about the SIMPLE study and about the use of pleural ultrasound. So this is a picture of lung sliding. As you can see, the pleural stripe moving up and down with respiration. And this is lost during pleurodesis. And as Rakesh mentioned, by measuring the loss of this lung sliding at different parts of the hemithorax, they were able to remove the chest drain post pleurodesis after 2 days instead of 3 days, instead of using just the volume of drainage criteria that was previously used. Then indwelling pleural catheters, which have rapidly or are rapidly becoming more and more used and standard of care. Well, there are definitely cases in which pleurodesis will not work, where the lung is non-expandable. That's either because the lung is entrapped, like this with a thickened visceral pleura, or there are multiple loculations and septations. The Time 1 study showed that at least at 6 weeks, no difference in terms of symptom control between chemical pleurodesis and IPCs. And of course, IPCs required less inpatient care. There were some complications reported with the IPCs. And then, of course, there was the AMPLE study, which looked at these patients until death or 12 months. And that showed over this longer period, the IPCs had less all-cause hospital stay, less effusion-related hospital stay, less ipsilateral pleural procedures. And when you look at the patients over this longer period, the difference in complications is not so stark. But IPC-related pleural infections is a real thing, and I don't want to minimize it. And as mentioned before, it's treated with antibiotics, and we don't have to remove the pleural catheter. These IPC-related pleural infections are related to multiple different factors, some of which are under our control and some of which are not under our control. And I think that what is important is aseptic technique in insertion of those catheters, as well as the drainage of those catheters. So it's important to have good procedures, protocols within your pleural suite, as well as to have good patient education or caregiver education in terms of drainage. You can also get some pleural catheter tract metastasis. There is no role or no evidence for the role of prophylactic radiation, and these tend to happen more commonly with malignant mesotheliomas. Other complications include symptomatic loculations and catheter blockage, and we have a protocol by using 2 mL of alteplase to unblock these catheters. As far as the frequency of drainage, the AMPLE-2 study has shown us that if you do more aggressive daily drainage versus less aggressive symptom-guided drainage, the aggressive daily drainage is likely to have a higher incidence of pleurodesis. I've already briefly mentioned the time-tree trial where urokinase was used for patients who had multiloculated effusions. As mentioned earlier, improvement in radiology and drainage, but no difference in terms of pleurodesis and symptom relief. A lot of the discussion has been focused on whether we should be using chemical pleurodesis or IPCs. And of course, IPC plus study challenges this and says, why can't we use both? So in this case, 10 days after the IPC was inserted, if the patient had an expandable lung, they had talc slurry instilled via the IPC, and you can see that the response or the successful pleurodesis doubled compared to those who did not have talc slurry. So how will we treat these patients? I think any one of these answers are possible. It depends on the patient. It depends on the histology. It depends on the functional status. It depends on the rate of reaccumulation of fluid. And I put surgery there because my patient actually had malignant mesothelioma. And there are some surgical options available for these patients, including pleurectomy, extended pleurectomy and decortication, and extrapleural pneumonectomy. Extrapleural pneumonectomy has sort of fallen out of favor these days after the publication of the MAS trial, although there were some problems with the power of the study and the dropouts. And now we await the results of MAS 2, which instead of extrapleural pneumonectomy looks at the role of extended pleurectomy decortication versus non-surgical treatment. The role of radiation therapy, as I said, not for prophylaxis, but for local symptom control. And also for malignant mesothelioma, we are increasingly moving away from systemic chemotherapy to immunotherapy as first line after the publication of Checkmate 743. I can't complete this talk on malignant effusions without talking a little bit about systemic management in terms of palliative care for these patients. That should not be forgotten. Patients should have breathlessness, pain, fatigue, and anorexia managed systemically as well as via pleural interventions. And so I'll come to my take-home slides. Well, malignant pleural effusion is not one single disease, or actually doesn't behave like a single disease. There's a different tempo to this disease depending on the underlying histology and the speed at which the fluid accumulates. Conventional wisdom is repeatedly being challenged by data. What we do will depend on patient factors such as comorbidities, the underlying cancer type, how fast the effusion reaccumulates. And I remind everyone, make sure we get adequate histological or cytological sampling because we need to treat the underlying cancer as well. And with that, I end. I hope I'm not standing in the way of your dinner. You must be quite tired after such a long session. Thank you very much.
Thank you very much. Thank you very much for your wonderful presentation. Actually, this is a really timely need presentation on the management of difficult to control effusion, mainly on malignant pleural effusion. I think we all face day-to-day practice. We feel this problem, how to manage this complicated pleural effusion as a clinician. And now, thank you very much for again. And we will open up for a question and answer session. And we receive the one questions from Dr. Sujit Rajan from India, directed to Professor Galili. I will read the questions. Many labs refuse to do N-terminal pro-BNP on pleural fluid for for fear of jamming their auto analysis if pleural fluid proteins more than 2.5. Any thought on how to get over labs to do this test? Director Professor Gary.
I fortunately never encountered that concern before, but obviously if you got frank pus or very, very thick fluid, then it would potentially block up many machines, and that would be not an unreasonable thing not to do it. But for most of the other fluids, the risk of blocking up machines will be significantly lower than blood, for example, which clots. So I can't see any reasons why the lab should not be doing it. And in the worst case scenario, biochemists would routinely dilute fluids and then just multiply the results with the dilution factors. So I really don't see any reasons why the laboratory should not be doing it.
Okay, I'd like to ask one question from Anandan. The place of betadine in the pleural disease of a malignant pleural effusion. There's a few papers and some meta-analysis on betadine, the providone iodine, because it's a very, very cheap and it's freely available in our hospital, and we are having some problem of getting this talc and other chemical. As you know that we are in a difficult time nowadays.
Yeah.
What do you experience on this betadine or providone iodine in the cases of malignant pleural effusion for pleural disease, chemical pleural disease?
Yeah, I don't have personal experience with betadine, but it is well known as one of the a number of chemical pleural disease agents. The data, of course, suggests that talc is the most effective, and I'm not sure it's much more expensive than the alternatives. Myself, I've sometimes used antibiotic pleurodizing agents when we weren't absolutely sure about whether infection could be excluded or not. So sometimes we use doxycycline in some patients as well.
Yeah, we also used earlier that the tetracycline and the doxycycline, and then that's one of my juniors so interesting about this so-called betadine in the pleural disease. Okay, yeah, Professor Gary, yeah.
I might just add in a little bit. Occasionally, we do use it, especially if people have failed talc, because the data in small studies from sort of Central American countries are similar. I think number one, you need to make sure that your iodine is not alcohol-based, because a lot of the sterilizing agent iodine has got alcohol in it, and it makes it a lot more painful. In our experience, it does hurt. So it probably hurts even more than talc. So we got very cautious nowadays. If we use talc, we sometimes even sedate the patients beforehand, or at least have that standby. Yeah.
That's another question I like to ask regarding the mixed diseases, where we, as you know, that we are having the tuberculosis is very common in our society, and sometimes we get the mixed disease, the tuberculosis and the bacterial infection or even malignancies. Just to get your experience on managing the mixed problem. They are the malignancy plus infection and the TB plus the malignancy, because we have feel that some situation we treat the malignant and then the patients are getting worse, and the TB also come into play when we do the investigation. Do you have a experience on the mixed clinical problems like that?
I probably have less, because I'm fortunate enough to be in one of the lowest instance area of TB in Australia, and Australia has got the lowest instance of TB in all OECD countries. So to have that together with malignant pleural effusions is uncommon for me. I would probably treat both. But I think maybe Dr. Devanand, who in Singapore might have a bit more experience than I have in joint problems, but I would probably treat both of them separately.
Yeah, I'll have a quick stab at it. I think we sometimes do encounter this, and the priority is always to first treat the infection, right? Because if you don't get control of the infection, the patient cannot get subsequent cancer therapy and so on. So and obviously in the infected pleural space, we try not to pleurodise the patient as well. we let the patient drain out all the effusion, the infection, and then we deal with the malignancy. Over.
And another question actually I'd like to ask about the place of blood patch, autologous blood patch in the cases of recurrent pneumothorax, particularly spontaneous. And I just open the question for finalists and Afla and Professor Gary. What do you explain? I mean, I have tried several times, but I'm very happy with that. Just to know about your experience about that. Are there any problem related to that except the pain?
I might let the other speakers try first. I think everyone.
I think Professor Gary is in a better position to.
The only thing I can guarantee is that everyone has a different opinion on the panel. I'm pretty sure.
So I have personally done on two patients, and like Dr. Dushanta said, and both failed. And currently, the patient who had a persistent air leak following, because most of these patients are with secondary pneumothorax we experience, and basically didn't try in those patients. So my experience is very much limited. But however, I have read quite a few papers, and some have gone into the extent of measuring how much of blood to be put in. So I really don't know how to just take those papers and to interpret.
Yeah. Our experience has been reasonable, I think. I wouldn't say it's been fantastic, but it's been reasonable. And typically, these are patients in whom surgical therapy is not an option. I think that one of the challenges is that we must make sure that the air leak is not too great, and the patient actually can tolerate a period in which the chest drain is clamped, such that the blood patch can go in. Because if they cannot tolerate that, then you're not going to be able to get the blood patch in. And of course, I think the other thing is that if it doesn't work the first time, sometimes we repeat it, and sometimes we get better chance the second time. Sorry, Gary.
Yes, Professor Gary. Yeah.
Yeah. So we've gone through different phases. There were some years that we truly believed in it, and then there were years that we think every time we just give the patient an infection. I think the main downside of blood patch is infection, because what we all do is that the patient has been having the same chest tube for 10 days, 12 days, and then full of bacterial colonization, and then we give them blood, which is the best culture media for bacteria into the pleural space. And it's not surprising that all literature suggests that there's a 10 to 20% infection rate. And so our surgeons used to mix the blood with antibiotics before they give it, but I don't think that works. We've tried antibiotics at the time when we give the blood, and it still doesn't work in all cases. But we now actually get to the stage where we actually cover the patient with a course of antibiotics over the next few days, and that seems to have done the trick. But we don't usually have to clamp the tube. What we usually do is to elevate the chest drain over the insertion point, like looping it on the IV giving set. And then so the fluid or the blood will stay in, but the air can still bubble out. So we don't clamp the tube for that reason. But the important thing is that blood often clots the tube. So you need to have a decent sized tube, because I think if you first started doing it, very often a couple of hours after you give the blood, it stops bubbling, and you get very excited that you think that the air leak has stopped, but it's all because of the blood clotting the tube, and the patient is worse off. So I think it needs to be quite careful about those things. Number one is the tube being blocked, and number two is about infection. I think the literature data is very controversial about it, and the studies that are published are not the best quality. Nowadays, in where we practice, we are very fortunate that we can use endobronchial valves, and endobronchial valve is a really much better option in most of the cases, especially if they bubble enough that my colleagues can actually see the bubbling when they do the procedure. Obviously, that is a lot more expensive than blood.
Thank you very much. I think because
can I ask a question from Professor Gary? This is about you, since you mentioned about this endobronchial valve. Now, some of these patients are, especially with the secondary pneumothorax patients, are quite ill, and like I discussed with this fungal pneumonia who had got into persistent air leak. So those patients are basically, sometimes they are not fit for surgery as well, especially when you wait for some time for the air leak to seal off with the time. And by that time, sometimes patients get, with these patients having other comorbidities. So in those cases, do you think that having an endobronchial valve early in the disease is helpful, or even rather than waiting for the persistent air leak to get sealed off?
Well, I think for a start, one of the downsides of endobronchial valve is obviously it increases the risk of infection afterwards because you can't clear the secretions. So I think we'll be very, very cautious if a person has got concurrent infection. We usually don't do that, for example, for people with abscesses and bronchopleural fistula secondary to that, etc. So we've never done it on people with fungal causes, but for the usual COPD, advanced COPD pneumothoraces, we have done a fair few. The biggest concern always is when you block off a lot of collateral ventilation, and as you know, the literature suggested that on average you need 2.8 valves on each of the patient to block off all the collateral ventilation. So you're blocking off quite a large segment of the patient's lung, despite them having already got very advanced COPD. So we have people who get quite short of breath and afterwards, but after a few weeks, we could potentially remove the valves. And we have seen some very significant benefits in those kind of situations. So it is obviously a difficult balance between all those factors, no question about that. Yeah.
Thank you very much. Having very sound and very updated discussion on the practical thing. And I am inviting my co-chair, Dr. Damit Nandadeva, to wind up the session.
Thank you very much. So to conclude, I would like to thank all the speakers for their valuable input. At very short notice, we managed to organize this webinar without any hesitation. The World Authorities on Pleural Disease agreed to join us this time as well. Thank you very much for your comprehensive talks on, I think we've covered most aspects, important aspects of pleural disease here. And once again, we look forward to working with you again in future for college activity. Thank you very much on behalf of the college to you all. And also, thank you for all the attendees for participating and questions as well. And we'll be organizing further symposia and webinar through the Pleural Disease Assembly of the college. And we'll notify you of these. Please look forward to further inputs from our college as well. Thanks also to Nalina and his team for technical support. I think they've been very busy and very organized as well. So let us end this session here now. Thank you very much to all who have contributed.